together. Okay. Welcome back, everyone. Hi, everyone, just coming in. All right, so we are here for another session. Hope you had a nice week, ready for the good weekend. All right, enjoy. Let's start our weekend with our special free NCLEX review session here from DiCarmel NCLEX review program. And as I was informed, you have the option to access the program either through Facebook or through YouTube. Yes, so log in through DiCarmel International Trainers. Hi, everyone. Nice to see you all. Nilam, Ruth. Hi, Maria. Thanks, everyone, for coming in for the session. Hope you could have another good time learning together. We'll just give a minute for everyone to come in. Probably it's, I am expecting many more candidates here from the US, and it kind of a little early here in the US. In the East Coast, it's 9 a.m., but then rest of the US is quite early. If you are there in California, it would be probably around 6 o'clock only. I hear you. All right. Okay. And good morning, everyone, again. All right, so I believe everyone is getting seriously ready for your exam. Yeah, the peak summer season is here for your exam. Hi, Jomia. Thanks for coming in. All right, and we're going to continue from what we were talking like last week. Yes, and as I told you, we're going to have this session extended for another half an hour more, I think. As I got the comment from many of you, an hour would be pretty much short. So we are going to have the session for the time being for an hour and a half. All right, okay, so And we'll have some good preparation over these few weeks. And as many of you are applying for exam this summer itself, this would be a good time for us to prepare. Those who are working busy on the weekend, this would be the perfect time to get some tips and guidance on your effective NCLEX preparation. And thanks everyone on the YouTube as well. Yes, everyone has joined the YouTube live as well. Thanks Albin for joining the session. Thanks Jomia. All right, so and as we were talking the last week, I'm just going to go back to pretty much the same what we were talking last week, and we'll continue from there. Why do we need to prepare so aggressively for the NCLEX exam? I mean, what do we think? What would be the reason why we need, how does NCLEX exam become harder? Right, we were kind of talking the last session as well, but in case if anyone didn't hear the session, so NCLEX exam is not just, I'm just bringing back the same image we probably saw the last week. Remember, we are talking about the Bloom's taxonomy, while many of the other exams are focused on knowledge, testing your knowledge. The NCLEX exam, by this time, we know it is testing your application analysis skills. So this is where we have to have a more aggressive preparation. Yeah, so this is where we need to have the right preparation in the right time so that you could get through this exam much more effectively. Okay, so yeah, the same image you saw last week, what you can see here, yes, it's not just testing your knowledge, it's going into application analysis level. And the current results, the statistics clearly show this is very true. I mean, if you look into, people do have a lot of myths regarding this exam, or this is I probably mentioned during the last session, this is the COVID time. Okay, this is the right time to get to the exam. No, it is not. And as I mentioned, I do have this statistical report from NCSBN. Yeah, the exam conductors itself for your visualization here to get started. Yeah, you can see how the passing rate is significantly varying for the US educated candidates and the students here, students from out of the country, international students pretty much from anywhere, because we do have a significant difference in the passing rate, and could be because of the effect of the system, the difference in the system of learning we have. So let's see what we have, what we can see here. The image could be a bit small, but I can just point it for you. So look to see how the students in the US, yeah, this shows the January to March results of the NCLEX-RN passing students here in the US. That's for the bachelor students. You can see the baccalaureate students. So their passing rate is 88%. For the associates like the diploma, their passing rate is 81%. While when it comes into international students, you can see if you are a first-time international student, your passing rate chance is 42%, approximately 43%. While when it comes to repeat takers, it is just 23.72. This information is not to discourage you, rather to make you prepare more aggressively. So we cannot take this test for granted like other exams, or you have your nursing license from our original licensing country, but that doesn't mean NCLEX passing is that easy. It's a bit different and it's a bit challenging comparing to how the students here in the US pass or in the Western system overall. So yes, I just want to make you well understood what happens with the NCLEX passing and the NCLEX exam. Okay, and other aspects of the exam as we have gone through, I'm not going to go back into that, but just want to get you a clear understanding of why we need to prepare much more aggressively for the NCLEX exam compared to other exams. And yes, so but that being said, let's proceed into more information. Thanks for many more people have joined the session. Thanks to Lily. Thanks Thanks, Ruth. Okay, everybody's coming in. All right, so let's get this session started with some question answer review session we're going to do. Okay, and also, yeah, the same information I told you before I get into the questions, just one other, or we'll give a couple more minutes for others to join. And as I mentioned, NCLEX exam is not just a computer-based exam, it is a computer adapted test. Remember, so it'll test you, it'll take you through the way based on how you respond to the individual questions. So that's where this test is challenging and different from other exams. So the reason why we had to be prepared much more aggressively, as I mentioned. And so how can we prepare more aggressively? Maybe you have heard this from me several times. My current students or my ex-students, some of you are in the group, as you can see. So this is what I keep saying every single time. The reason why we are having the candidates know most of the information, but they are still failing to pass. Why does that happen? Probably because of our defective system of learning, which is memorizing. So that's why we had to change, and we had to get into better, deeper understanding. Yes, you had to start to comprehend. So unless you have that understanding, when you see the information in a question, if you change it a little bit from what you know, you're not able to relate and connect and reproduce information to answer the question correctly. So that's why, yes, my one single advice for everyone who is listening to me at this time: stop memorizing. Yes, you need to know the content. I'm not saying you don't have to know the facts, you need to know them, but stop memorizing them. Make it a more creative, understandable learning. That's what, you had to comprehend the topics. So again, that being said, we're going to get into the question answer session for the day. Again, I know many of you are getting seriously ready for your exam, and this is what you want to hear more rather than other part, right? Okay, yes. And I kind of know many of you are in your serious preparation by this time. So let's get into the question answers here, and I'm going to show the questions one by one. And also, yes, you can type in your response. By the way, if you can, all of you, if you can, please type in your location where you are from, which country or which state you are accessing it from. That'll be good for the viewers to know how far we are reaching out, and also can recognize you, anyone who is accessing for the first time. So please do type in your comment box where you are accessing our live session from. All right, so let's proceed into the question answer session here. Okay. All right, the very first question. So what I'm going to do, I'm going to show the questions one by one, probably the same way as we did the last time. Then I'll go into a detailed rationale why that particular answer is right or wrong, yeah, with the related pathophysiology. So, by the way, one thing I want to emphasize here, as you would have noticed in my flyer, like it's a pathophysiological approach. This is where most students get challenged. I mean, again, I told you they try to just simply memorize the facts without having a clear understanding of what is happening with that particular disease condition. That's where our lesson is going to be highly emphasized on the pathophysiology. So once you know the pathophysiology, it's much more easy for you to relate to the other aspects of how to treat, what medication, and so on. So that's why everyone try to understand the topics based on the pathophysiology. All right, so let's start our question and answer session here. Here we go. I'm going to get you few seconds, maybe 30 seconds to read it, and we'll proceed from there. All right, so take your time. And you're welcome to type in your response in the comment box, what answer you think is right. And I'll come into the explanation of the answer towards the end of our discussion of this particular question. All right. All right, I'm waiting for your responses. Yes, you are welcome to type in your response. You don't have to make anything detailed. Just say if it's A, B, C, D. All right. And that has to come to either the Facebook or the WhatsApp chat box, please. I meant the Facebook or the YouTube chat box. Since there is no one else to give me a second hand, yeah, I won't be able to look in many places. Yes, I'm just monitoring my Facebook responses and the YouTube responses. All right, so I'll be getting some responses here. Okay, okay, I can see people coming with. I got a B. Okay, I'm getting a C. All right. Okay, so more people coming in. Okay, I'm getting B's. Thanks everyone. The YouTube watches as well. Yes, Seema, and there are many more. I'm trying to locate you guys. All right, so yeah, I think we had enough time. Hi Ashwati, thanks for coming the session. And as I mentioned, if everyone can just type in your location as well from where you are accessing this live session, please. All right, so okay, I'm getting a lot of B's here. Okay, so let's read this question together. Okay, and just one quick second, I believe we can. Okay, so let's read this question together. Okay, so a patient who has been ordered for RSD immunoglobulin correctly understand the need for the medication if she makes which of the statements? Okay, and I'm sure everyone might be familiar with this topic, what we are referring to, what we call RH incompatibility, right? A very classic problem we encounter during pregnancy with related complications that can happen to the fetus. Okay, so that's what the part of the question is. Yeah, the purpose of the question is focusing on RH incompatibility, and the options we have. First option, negative isosensitization is a contraindication for injection. Option B, once she has positive COOMB'S, she'll be ready to go for the injection. Option C, it can help to prevent pathologic jaundice in the newborn. Option D, this one-time medication will give her the protection for the rest of her pregnancy. All right, I can see most of you have responded B. Okay. All right. I wish if you had a chance to talk together and clarify. Okay. So now, before I say what the answer is, I'm going to go into the facts. All the facts related to RH incompatibility. I'll go from there, and then we'll see this question once more towards the end of this particular discussion. All right. So this is what we have. Okay. Again, a topic that is quite familiar for everyone. Even though you might not know the super details, or is coming up in a second. All right, so you can see RH incompatibility. So how does it happen when the mother is RH negative? Yes, as you can see, the image shows the mother who is RH negative and the baby is RH positive, right? That's what the situation is. And as we know, in a normal healthy pregnancy, the cells, the blood cells of the fetus doesn't mix with that of the mother, as we are aware, because there's a clear protection between the mother and the baby through the placenta. But in an event that can cause a tear or rupture of the placental surfaces or membrane, the fetal RBCs, the positive RBCs, can get into the RH positive cells, can get into the mother's blood. As you can see, yeah, the baby's blood can get into the mother's blood. And now what happened? The RH negative mother is going to have the RH positive cells. Yeah, the RH negative mother is going to have the RH positive cells. And anything that doesn't belong to us, right, our body respond. So the mother's body will respond here by producing antibodies. And yes, again, when the mother is RH negative and when the baby is Rh positive, in an even, again, a rare situation, the baby's blood cells can get into the mother can start to produce antibodies against the fetal cells. And that process is what we call as Rh isosensitization. What you can see right here on the very next screen. Yes, and what I told you is exactly what you can see right here. Yes. So Rh isosensitization is also called isoimmunization or alloimmunization. So how does it happen? Yes, again, we can read it together. It occurs when the Rh positive blood from the baby causes the mother's immune system to produce Rh positive antibodies. The same what I told you. That can eventually destroy the baby's blood cells. And yes, when that happens, that's what we call as erythroblastosis fetalis. And I'm going to go back into this image for one more second from where we came. All right, so yeah, and as I told you, in normal case, the fetal blood does not get into the mother's blood. And the same way, the mother's blood doesn't go back to the fetal blood. That's how it is normally. So because of some tear, if the fetal blood got into the mother's blood, the same way the fetal cells also, the mother's blood also can go back to the fetus. So we're talking if the mother produced the antibodies, the Rh positive antibodies, we heard it, that's called a Rh isosensitization. If those positive antibodies developed in the mother, if you get back into the fetus, that can cause destruction of the fetal RBCs, resulting in hemolysis of the fetal blood. And that is what we call as erythroblastosis fetalis, as you can see right here at the bottom. Here we go. Yes, that's what we call as erythroblastosis fetalis. When you hear the term erythroblastosis, you might understand, it's destruction of the RBCs. What is the function of RBCs? To transport oxygen, right? So when they decrease, the baby or the patient can become anemic, right? It can become significantly anemic. So that's what the situation is. And also we have a few other facts to know regarding this. So how do we prevent it? So we can prevent this condition through testing the mother's blood. As you can see on the very next screen, we can test the mother's blood during her first visit, and also during the second trimester, mother would be tested, as you can see, on first antenatal visit, and also during the 28 weeks, mother's blood would be tested for any identification of antibodies, and that's what we call as indirect COOMB'S test. Yeah, testing the mother's blood to identify for the Rh isosensitization, that's what we call as indirect COOMB'S test. And also it may be done following some traumatic events. For example, maybe a fall or an injury, some external trauma, or maybe even after termination of pregnancy, etc. So there is a high risk of this mixing or amniocentesis. Those are the times the blood may be tested for this high risk or the high chance of isosensitization through the indirect COOMB'S test. And also at the time of birth, we test the baby's blood to see if the baby has developed or has gotten the antibodies from the mother. And testing the baby's blood, that's called direct COOMB'S test. Yeah, you can see there is indirect COOMB'S test done with the mother's blood, and then direct COOMB'S test done with the baby's blood, which is done at the time of birth. And these both must be negative for the mother to get the RSD immunoglobulin. And that's what you can see right here on the next page, the next screen. You can see the criteria to receive the RSD immunoglobulin. So both these indirect and direct COOMB'S tests must be negative. And also the baby must be Rh positive. So this is the only situation, these are the situations where the mother need to get the RSD immunoglobulin. Again, so both the mother and the baby should be negative. That means the mother hasn't gotten the Rh positive cells from the baby, or the mother hasn't produced the antibodies, or the mother hasn't transferred that back into the baby. So once all this criteria is met, that's when, and also the baby should be Rh positive. The baby is Rh negative, there is no need of any of these things, because there is no even of this transfer of the fetal cells to the mother and the production of those antibodies. So then they don't need to get it. If it's Rh negative, they don't need to get it. So meeting all these criteria, so that's where the mother need to get the RSD immunoglobulin. Okay, so having said that, we're going to go back to the question. Here we go. So based on our discussion, if you look back into the options, what do you think now? And as I identified, many of you sent your answer as option B and with some rare C's. But let's see the truth here once more. Okay, so a patient who has been ordered for RSD immunoglobulin correctly understands the need for medication if she makes which of the statements? Option 1, negative isosensitization. Okay, we just heard, so they need to have negative isosensitization. So it's not a contraindication, that's an indication. So option A is out. Option B, once she has positive COOMB'S test, she will be ready to go for the injection. Well, we said if she is positive, she cannot get it. Positive shows already she produced the antibodies. And what are we trying to prevent through this RSD immunoglobulin? We are trying to prevent the mother building up this RSD immunoglobulin. We are trying to prevent the mother producing the antibodies, what we call, we're trying to prevent the RS isosensitization. So if she's already positive, this is not going to work. So that's why, I'll give you a simple example. Suppose someone is hepatitis B positive. When should someone get the Hep B vaccine? So it should be given before the person become Hep B positive. Once it is positive, the vaccine will not help. The same way, once the mother is positive, it is of no use. So that means A and B are out. So now we are between C and D. Okay, looking into option D, this one-time medication, no, it is not one time. So this same sequence has to be repeated every time when an RS negative mother bear an RS positive baby. So the same process has to happen to protect the mother from the isosensitization with the goal of protecting the fetus. Again, we heard that if the problem happens, if the antibody formation happens in the mother, who is going to be affected? It's going to be affecting the fetus, because when the antibodies, the RS positive antibodies that has been formed in the mother, if you get back into the baby, that can cause destruction of the fetal cells, resulting in what we call as the erythroblastosis fetalis. So if that happens, means there's rapid hemolysis, that can cause, there is a significant increase in the bilirubin level, and it can cause the baby to develop pathologic jaundice. And therefore, the answer in this situation is option C. And I hope that was understandable, everyone. All right, and yes, I believe everybody is making use of the session, and please type in any concerns, any doubts you have, and I'll be ready to explain further to improve your understanding. Thanks everyone again, yes, so joining the session, Nasir, and as I told you, if you guys, yes, I can see Alvin from Toronto, Canada. If others, you can type in your location as well. Appreciate your help. Okay, I can see Ruth from Oman. Maria, you have joined from United Kingdom. Okay, so I believe it's reaching to everyone in need all over the world in the right time. Yes, again, this is the peak time for the NCLEX preparation. Yeah, here this is a time the students graduate here in the US with many more students in need of the service. So that's why we thought of conducting this session, particularly in this summer time. Yeah, this is summer here in the US. All right, almost getting into the summer. Okay. All right, so hope that was clear, and let's go to the next question here. Here we go. All right, so which of the following finding in a baby born to a mother who is RS negative and the father is RS positive would alert the nurse? Okay, so it's a clarification of what you learned in the very last question. Okay, so hopefully you might be able to answer this right this time, right? So now you have a good understanding. See, doing more questions related to the topics that are said to be or considered as challenging will really help you to get your concepts thorough in that area. Thanks, Nilam from New York. I can see Okay, New York participants. And I can see Ashwati from India. All right, so let's see what the response we have here. All right, so once more, I believe this wasn't that bad. I don't have to go back and explain the whole process because we just went through, right? So which are the following finding in a baby born to mother who is RS positive, RS negative, and father RS positive? By the way, if I didn't tell you before, this is how it is. Usually when the mother is negative, father is positive, almost 65% babies are RS positive. Yeah, so almost 65% babies, almost 2/3 of the babies become RS positive. Okay, so which of this needs to be alerted or need to be taken with a consideration or due importance? That's what the question is asking for. All right, and if everyone can type in your response, I can see option C, I can see options D, okay, I can see option A. Okay, thanks Seema from Maryland, Nasir from Virginia. All right, so let's see what the response here truly should be. Okay, so would alert the nurse. Remember, would alert means something concerning, and we're talking. Okay, so I can see no one choose option A or B. Okay, so everyone know. Okay, that's within our knowledge, right? Respiratory rate 58, that is within the normal for a newborn, and so was heart rate within normal. And whereas pallor, okay, what does that indicate? And what about the negative Coombs test? I mean, we already heard what we want is negative Coombs test. So do we want positive Coombs test? No, we don't. We want the negative Coombs test. That means that there is no isosensitization. There is no mixing of the baby's blood with the mother's blood. So that's what the negative Coombs test. I mean, the indirect Coombs test we heard is done with the mother's blood before delivery, and at time of delivery we do the baby's blood test. That's the direct Coombs test. So, and we want the negative. So that means the negative is not a concern. That's perfectly fine. So what are we left here? So that's what our answer is, which is option C. And why? Again, going back, remember, what is the condition called? RS incompatibility. We also call it as erythroblastosis fetalis. We're talking, it can cause rapid destruction of the RBCs, so they can become extremely anemic. And also they can have jaundice. So that's why the answer here is C. I hope that was understandable, and if anyone still need clarification, please type in your question and I'll be able to get you further explanation within my limitations. All right. And also those who are watching this session, yes, both on Facebook and YouTube, I request you, all of you, please share this with your friends. If you can share it right now, it can bring in more viewers, and people can get to know the service we offer here and can benefit many people. All right, so then let's go to the next session. All right, so I can see more people coming in. I can see Maria. Okay, and again, everyone who is coming in, if you can just type in your location as well from where you are watching the session, I appreciate it. All right, so let's see the next question we have here. Here we go. All right, so terbutaline is recommended for preterm labor because, yes, so they all are 4 options. Yes, it's a safer bronchodilator that can be used during pregnancy. It has a beta-adrenergic effect in uterus. It is effective to relieve the shortness of breath associated with the last trimester of pregnancy, and it's associated with the less fatal complications if used in pregnancy. All right, so if you can type in your responses, if you understood the question at this time, we can go into the discussion. By the way, many of you might know terbutaline is a bronchodilator, right? That's a bronchodilator, just like albuterol or aminophylline is a bronchodilator as well. But why do we use that in pregnancy for preterm labor? Okay, so yeah, I can see many of you responded B and then C. All right, so before we disclose what the response is, and I can also see some of you went with the D. Okay, if anyone else, please send your response and I'll go into the explanation how this can be figured out. All right, so let's see what we have here. All right, so by the way, okay, we are talking about preterm labor. We're talking about preterm labor. So when preterm labor begins, right, labor before the end of 37th week, we know it can be accompanied by several complications because the baby is not mature, particularly the lungs are immature with a lot of respiratory complications. They may have to be on a ventilator, on an incubator. All those complications we are trying to prevent by delaying the labor as much as we can. And so that is done with the help of the drugs what we call as tocolytics. So as you can see right here, so this is how we typically manage preterm labor. So unless harmful to mother or baby, the labor will be attempted to be arrested with the tocolytics. Now, if anyone wonder what is tocolytics, so tocolytics are the drugs that will stop the premature labor process. See, these are the drugs to stop the premature labor. Now, I know people who disregard maternity and focus more on med-surg or other areas. But let me tell you a sincere, serious advice. There is no part of NCLEX that is insignificant. Every single content is having its own significance or importance. So make sure every single area is reviewed. And this area I'm going to discuss here is a super classic topic, which is reported by so many people from their actual exam. And this is also the way how we can actually understand medications. Don't try to simply memorize medications and its tons of side effects. That wouldn't help you in the NCLEX. Always try to relate that with a certain topic, and that'll help you, your learning much more meaningful. So now let's look into a bit more about tocolytics. So what you can see here, okay, this is a list of the drugs we use to treat premature labor, as you can see right here. Okay, so that include magnesium sulfate. And how does it work? You can see how it's being explained or how it acts. It acts on the myoneural junction and stop the uterine contraction. And then there are beta-adrenergics such as erythrodin, isosuprin, terbutaline, which are beta-adrenergics. And there's calcium channel blockers such as nifedipine, prostaglandin inhibitors, indomethacin. There are other drugs. And also to improve the lung maturity, there are some other drugs. Out of this whole list, what you can see here, up to here, this is what we call as tocolytics. The first four in the list are the tocolytics. These are the drugs that will stop the premature labor by different mechanisms. Yeah, again, it could be magnesium sulfate, beta-adrenergics, calcium channel blockers. Yeah, calcium channel blockers, they have a smooth muscle relaxant effect. So that helps to relax the uterine muscles and stop the premature labor. And so as prostaglandin inhibitors that can stop the contractions. We're going to have another question related to prostaglandin inhibitors, which will make it clearer for you on the way. And also, let me just explain a bit more about beta-adrenergics in a comparison with this information I'm going to show you right here. Okay, so what you can see here is the adrenergic effect of various receptors and its actions. Again, a topic we're going to go over probably by itself another time, but I just want to get you an overview in this particular situation. we won't have time for the whole being explained. So what we have here is the different receptors which could be stimulated with adrenal stimulation, what we call alpha 1, alpha 2, beta 1, and beta 2. And you can see the beta 2, the one at the very bottom, the beta 2 adrenergic effect. What effect it has? It has a smooth muscle relaxant effect, which is acting in 3 different locations. You can see it's acting in the arterial wall, in the bronchial wall, and in the uterine wall. So when it acts in the uterine wall, how does it work? It causes uterine relaxation. So here we go. So this is the one we are referring to in the question we just saw. So you can stop the premature labor by relaxing the uterus. So that's the point, the information we need to know in order to answer this particular question. And hope that was understandable. And again, we'll have a detailed review of this on the way as a single lesson itself, likely. Okay, so and also before I show the answer, just a couple of things. Okay, I told you. So there are other drugs in the list as well, like a B. Okay, so if you can see this here. Okay, I told you in the list the first 4 are tocolytics, but then the other drugs in the list are not tocolytics but are misunderstood, and a lot of times the candidates answer it wrongly or learn it in a different sense. So I'm going to bring you what exactly betamethasone does. I mean, betamethasone, again, the first 4 are tocolytic. They will stop the premature labor. Betamethasone is not a tocolytic. It does not stop the premature labor. But what it actually does, it helps due to some unknown or not a very clear mechanism. Okay, you can see right here on the very next screen, it doesn't stop the premature labor, but it improves the fetal lung maturity if preterm birth occurs. So that's how it helps. Again, it doesn't stop, but if even after trying the medication, the labor cannot be arrested all the time. So if that happens, this drug might help to improve the lung maturity in the fetus with the minimal fetal complications and the maximum chance of survival of the fetus. So that's how this drug will help. Again, not a tocolytic, and this is given typically as 2 doses, like 12 mg over 24 hours as 2 doses, or maybe as 6 mg of 4 doses. I hope it was clear, and again, that's why it will not help. And by the way, the last one more drug is there in the list. If you notice the very last one at the bottom, you can see once, even after trying all the tocolytics, sometimes it doesn't work. That's where the baby could be born with immature lungs, and in that case, in order to improve the lung maturity, these are the products we use, what we call EXOSURF or Baractin. So these are surfactant products, and I believe you might know surfactants are the oil-like substance which is naturally there in the lungs, right? Which prevents our alveoli from collapsing. Yes, you can see right here on our very next screen. Yeah, so these are the products in our lungs which include lecithin and sphingomyelin. In a mature baby, they should be present at a certain level, which is at a ratio of 2:1. If it is less than that, they are not able to properly function the right way. They can have a risk of respiratory distress, and they can end up on the ventilator. So that's where we are trying to improve the lung maturity with the help of these surfactant drugs. And I hope it was clear. So with that explanation, so we'll come back into the question once more, and I think the answer should be clearly understood at this time. So terbutaline, why it is recommended for preterm labor. So we know this is direct answer right now for our understanding, our knowledge. So it has a beta adrenergic effect in the uterus. It has nothing to do with the relief of shortness of breath, difficulty breathing in the last trimester. We know that's a natural process of the pregnancy progress, and we know as the fetus descend by the end of the pregnancy, that's when the mother usually gets the relief. But medication doesn't really help for that process. So therefore, our best answer in this case is option B. And you are welcome to type in, ask any questions again for clarification. All right, so let's go to the next question here. Okay, so let's read it together. Okay, so discharge teaching for a woman who underwent dilation evacuation for gestational trophoblastic disease would emphasize which of the following instructions. So option A, pre-pregnant folic acid vitamins can help to minimize the occurrence of this condition with next pregnancy. Option B, early prenatal checkup can help to identify the condition and minimize complications with next pregnancy. Option C, practice of effective contraceptive methods is vital to minimize the complications of the condition. And option D, genetic counseling may be required to avoid the occurrence of this condition with the next pregnancy. And just for information, NCLEX is so specific in the selection of its content and the kind of the questions they ask. And this is what I tell, if NCLEX asks you a question from this topic, so this is what it is being emphasized, and I'll tell you what it is in a second. All right, so what we need to know with each of this topic is practically it's impossible to memorize every single facts from each topic to pass NCLEX. So rather, if you can know the content in general, and also by doing more and more questions, you will come to know what is really important. So what is science? Okay, I can see people typing in different responses. And if everyone can send you responses, please, I can see. I can see B, I can see C, I can see A. Okay. Okay, the first one, if you consider folic acid, remember folic acid deficiency has nothing to do with the trophoblastic disease, gestational trophoblastic disease. That is related to spina bifida, right? The neural tube defects prevention. So if anyone went for option A, that is not the ideal response yet. All right, so now, before I go further into the answer, I'm going to bring up some related facts here from the condition. Yes, so let's see what we have here. So gestational trophoblastic disease is what you can see here. So where the chorionic villi kind of grow, multiply into grape-like vesicles filling in the endometrial cavity. And what is special about this condition is their HCG level can significantly go high. And that's what you see here on the next screen. You can see how the HCG level in different pregnancy conditions are. Like in normal, it should be within the normal limits. I believe all of you know, right? The human chorionic gonadotrophin, right? The one which forms the base of the pregnancy test itself, right? And whereas ectopic, it can go down. Remember, ectopic is the tubal pregnancy, typically that happen in the fallopian tubes, where the chorionic villi cannot really grow and develop, so the HCG level can actually go down with ectopic. Now, whereas with the hydrated form mole, the level can go high. So that's the condition we have here, and that's our concern. Now, if the HCG level go high, there is a complication which can happen. That's what we need to know. And I told you, in relation to each topic we come across, there is a specific question NCLEX will target you on, and that's what we need to know. And as I always tell, don't go for the exam without knowing those facts. And this is what we have here. On the very next screen, you can see the complication of gestational trophoblastic disease. Yes, rapidly growing trophoblastic tissue It is usually benign at the beginning, but then later it may lead to cancerous changes. It can lead to trophoblastic neoplasia with the development of a condition what we call as choriocarcinoma. So that is the concern we have here. So this condition can lead into a cancerous development. That's the point we need to know. And let's see that once more. I can see some more description how gestational trophoblastic disease can lead into choriocarcinoma. So how we can prevent it? That's what you see right here. To prevent it, patients should be instructed to avoid pregnancy for at least 1 year in order to prevent increase in HCG. We know that with the subsequent pregnancy, there is a further increase in the HCG level. So already the HCG level is high, and it's going to go further higher with the condition. So that increases the risk of development of this cancer condition, what we call as choriocarcinoma. So that's what we're trying to prevent by delaying the pregnancy for at least 1 year. And also for the same reason, we need to have their lab studies monitored more closely. And also we need a prophylactic radiation or chemo being provided as needed to prevent development of the choriocarcinoma. So from this description, you would have clearly understood what would be the ideal answer for the situation would be. Okay, so now the answer become pretty much straight. Option A, we already eliminated. And some of you also give me option D, genetic counseling. That might be needed, but the priority, the most essential information would be to delay the pregnancy. That's option C, practice of effective contraceptive methods to minimize the complications of this condition. I told you, subsequent pregnancy cause the HCG level to go high, and rising HCG can lead into what we call as choriocarcinoma, a cancer condition. So therefore, our answer is C in this case. All right, and hope it's clear so far, everyone. Okay, so thanks everyone for coming for the session. Jocelyn, Stanley, okay, thank you. All right, so let's see the next question we have here. Okay, appears to be a short, simple question. Is it really is? Which of the following is an action of prostaglandins? Vasoconstriction, anticoagulant, stop contractions, decrease acid production. And as usual, you may please type in your response whatever is the answer you think here. All right, so I can see. Okay, you can see B, C. All right, so what is the truth here? Okay, so in order to understand this information, again, as I keep telling, this is where we need to stop memorizing and come to the point of clear understanding of the content. I mean, how do you memorize all these facts? Practically, it's not possible. Try to have that right understanding, and then whatever way the question comes, you'll be able to reproduce your answer. So that's what I extremely highly emphasize. And that's what will make you pass the exam. Okay, so stop memorizing and start understanding. All right. So let's try to understand what these prostaglandins are. I mean, So which of the following is an action of prostaglandins? And in order to understand what prostaglandins, I want to bring you into a quick comparison of what we call this table. You can see right here. Here we go. So what you can see here, okay, just one quick second. Okay, so you can see the table coming up here. A comparison of prostaglandin and the prostaglandin inhibitors. So a lot of times you can find remember, retain, and easily identify the answer through a clear comparison. So you need to know what is prostaglandin, and you can compare that with the prostaglandin inhibitors. So this is what I strongly tell. Okay, if you don't know what is prostaglandin, fine, but you definitely know what is prostaglandin inhibitors. So relate what you know to find what you do not know. So prostaglandin inhibitor is exactly the same what we call as NSAIDs. And tell me if there is anyone who doesn't know NSAID as a nurse. No, everyone knows that, right? And the drugs which come under the list, the NSAIDs, you can see Motrin, indomethacin, aspirin, right? These all are the super classic NSAID drugs we talk. So whatever action or indication that you know in relation to NSAIDs, the prostaglandin inhibitors, just the opposite action is there when it comes to prostaglandins. So for example, if you look here closely, what you can see, okay, so let's take the first one. Okay, so you're going to see this is prostaglandin inhibitors, the NSAIDs, and then prostaglandin in the first column you can see, and the examples as well in the intermittent columns. Okay. So take the case of Motrin. Okay, so who doesn't know Motrin, right? Ibuprofen. We know it's a strong gastric irritant, right? So when we take that, there's a high risk of developing GI irritation, peptic ulcer with the chronic use. That's a high risk problem that can happen. So just the opposite action is there for prostaglandins. You can see that reduces acidity. So in fact, prostaglandin is a drug we use to treat the acidity and peptic ulcer that's induced by NSAIDs. So just the opposite action you can see. And so as when it comes into the next action, okay, so indomethacin, we were talking this before. If you remember, this is a drug used to stop premature labor. So this is a drug that's used as a tocolyte. It can stop the premature labor process. So, and also we definitely know prostaglandins are drugs we use to induce labor, right? It is to induce contraction. And the number one drug we know is misoprostol for the purpose. And again, we know NSAIDs, they are antipyretic, right? Used to control fever. And whereas prostaglandins are pyrogenic, we can increase the body temperature. And then you can see prostaglandins are, NSAIDs, prostaglandin inhibitors are vasoconstrictive, so such as indomethacin. We're going to see that a super classic question we come across. This is a drug used to treat PDA. We're going to see what PDA, patent ductus arteriosus. It's a condition where the ductus arteriosus is still, the connection between the pulmonary artery and the aorta still remain patent, allowing the aortic blood to flow back into the lungs. So in that condition, in order to close the defect, we use indomethacin, which is an NSAID, because it's a vasoconstrictor. It will close the opening. And whereas prostaglandin has the opposite effect. Now, just skip the next one. I'm going to come into that in a second, and let's go down. So let's see aspirin, okay, the second last one at the bottom. Who doesn't know aspirin is an antiplatelet drug, right? The reason why we use to prevent clot or reduce the risk of coronary artery disease, etc. is a preventive or a prophylactic drug, as we know in most cases. And whereas prostaglandins can cause platelet aggregations. You can cause the platelets to come together, resulting in clotting. And the last one at the bottom, prostaglandin is used as prostaglandin inhibitors used as an analgesic, right? It's an NSAIDs are analgesic to relieve the pain, whereas prostaglandin will increase the pain. So basically, they all have just the opposite action, except for the one we didn't say yet, the effect in the bronchi. So when it comes to the effect in the bronchi, they can have the same effect or the opposite effect based on the kind of receptors. By the way, there are three types of receptors we talk when it comes into prostaglandin, that include PGE1, E2, and F2 alpha. So as you can see, the first two, E1 and E2, have effect to cause bronchodilation, whereas F2 alpha can cause bronchoconstriction. So that's why a drug such as carboprost, you will see this specifically in question, is contraindicated in asthma patients because it can cause bronchospasm, it can cause the patient's asthma symptoms to worsen. And so as aspirin is an NSAID, is a prostaglandin inhibitor that also can cause bronchospasm. So if you see this in NCLEX question, it is usually a contraindication. So even though they are coming under the two categories, the prostaglandin and prostaglandin inhibitors, they both can cause bronchospasm depending on the receptor, as we learned. So basically, as I told you, they have prostaglandin inhibitors, and prostaglandins have just the opposite action except for its effect in the bronchi. And also, to make it more specific, the action of prostaglandin is they are kind of chemicals which are produced at the site. You can see right here. So these are, okay, I have the screen right here. So prostaglandins are a group of lipids made at the site of tissue damage or infection. So they have a role in inflammation. They can create inflammation. And NSAIDs, prostaglandin inhibitors, have the opposite effect. Yes, so again, prostaglandins have a inflammatory effect, right? And the opposite, whereas prostaglandin inhibitors has an anti-inflammatory effect. That's what we can understand. So now if we go back into the question once more, okay, this is what I was telling. The drug is used to NSAID is used to treat PDA. The drugs such as indiremethasone is used to treat PDA. As you can see, it can close the open defect. Yeah, the defect that which is open here can be closed with the help of NSAIDs, particularly indiremethasone. Okay, and finally, just putting them together, these are the actions of prostaglandins. So they help for platelet aggregations. It can cause pain. It's not a good thing, but it's a symptom. It's a problem. It can happen when there is a release of prostaglandin. Again, when we have a cut or an injury, there is a release of prostaglandin causing this pain. And they have a vasodilator effect. It can induce labor. We heard it's a drug used to induce labor, cause inflammation, decrease GI secretion. And I was telling, when NSAIDs, prostaglandin inhibitors, can cause peptic ulcer or GI irritation, prostaglandin can decrease the GI secretions, can heal the ulcer in the GI tract. And also finally, it's affect bronchospasm or bronchodilation depending on the receptor. So this is with the prostaglandins, whereas prostaglandin inhibitors have the opposite effect. So which can have antiplatelet, analgesic, vasoconstrictor, tocolytic, anti-inflammatory, and also they increase the GI secretions as we learned, and also can cause bronchospasm. So from what we learned, now it should be clear and straight, right? Our information. So the action of prostaglandin. So what would be the fact here? The answer would be, so prostaglandins, we learned, they don't stop. If anyone chose C, it does not stop the contractions. It's a drug used to induce labor. Remember, it's a drug used to induce labor. So C is out. Prostaglandins, we didn't say it's anticoagulant. We said prostaglandin inhibitors like aspirin has an anticoagulant effect. So B and C are out. Now, prostaglandin inhibitors cause vasoconstriction. So not prostaglandin. So A, B, C are out. So our answer is D. We heard prostaglandins are drugs used to treat NSAID-induced GI irritation. So our answer became D. All right, thanks everyone. Still keep watching and for your support. And if you have any questions, please type in and we can have a discussion to make it more interactive and lively. All right, so and also as I told you, please share it with your friends, anyone in the group. So bringing in more people for those who are in need as well. And let's see, yeah, I think we have another 20 minutes to conclude the session and we'll have time for a couple more questions. Let's see the next one here. Here we go. All right, so let's see what we have here. 60-year-old Richard with persistent atrial fibrillation has been on heparin for the last 1 week. And as a part of his continued anticoagulant therapy, he has been started on coumadin 5 mg 2 days ago. His PT-ANR from the morning is reported as 17.2, 1.3. Which of the following actions, if taken by the nurse, is most appropriate? All right, so the options we have: continue heparin as ordered, notify MD expecting an increase in the coumadin dose, continue the coumadin as ordered, and the one at the bottom, notify MD expecting an increase in heparin dose. And notify MD expecting an increase in the heparin dose. All right, so I can see different responses coming in. Okay, so okay, so let's see how we can figure out this question. So when you see this question again, we should know, as the nurse, we need to know the whole scenario, how this anticoagulant therapy works, right? When a patient is coming in with an onset of some sort of clotting condition such as DVT or atrial fibrillation, which can lead into a clot condition, can lead into stroke, etc. So that's where this patient may go on anticoagulant therapy. And the strategy of anticoagulant therapy is what I'm going to show you here, and how it works and what we expect is what I'm going to show you here on the very next page, as you can see right here. Okay, so what we can see here, so when a patient first coming in to the emergency room or get hospitalized, we'll start the patient on heparin, and while they are on heparin, we look for the PTT. And what is normal PTT is 25 to 35 seconds. And once this heparin starts to work, right, what we call, once it becomes therapeutic, we switch them into coumadin. So this is the usual strategy of anticoagulant therapy. So then, while again they are on heparin, we look for PTT, partial thromboplastin time. And what's the normal PTT? 25 to 35 seconds. So what do we expect when this patient go on heparin? So it doesn't just stay there, it go into almost 2 to 3 times the base value or the control value. So suppose if the value is 30 seconds, it should go to approximately 60 to 75. So when it goes into the range, that's when we call it become therapeutic. If it is less, there is risk of clotting. If it's more, there is risk of bleeding. And once it becomes therapeutic, before the patient usually discharge home, they'll be switched into the next drug, which is coumadin, the oral one they can conveniently take at home. So when patient is on coumadin, we look for PT-INR. Now, what is normal PT? It's 12 to 13. Again, for a normal healthy person. When they go on coumadin, what we expect is this value should go 2 to 3 times. So approximately we can say it should go around 20 to 30. If it's within this range, then they are safe and it's a therapeutic limit. There is no further risk of clotting at that time. If it is less, there is risk of clotting, but if it goes higher than the upper limit, then there is risk of bleeding. So that's why we had to closely monitor this value. And so suppose, again, the base value, if it is 12, and when the patient is on the medicine, suppose it goes into 24, that 24 divided by the 12, that's what we call as INR. So that's the international normalized ratio, which is the patient's PT while on coumadin divided by the normal PT. So that you can see approximately become 2. So that comes into the normal range of 2 to 3. So going back to the question, we can see, so here in this question, the INR, PT-INR value is only 17.2 and 1.3. So that is lower than what is expected. So that means we need to increase the coumadin. Okay, so by the way, the question starts speaking about heparin, right? It starts about heparin, but then it switches into coumadin. So starting with the heparin is only a distractor. So therefore option A, and also PTINR is not relating to heparin, it's related to coumadin. So option A is out and option D is out. It's not anything to do with the heparin, it's related to coumadin. And since this value 17.2 and 1.3 is low, the coumadin dose need to be increased. So we need to notify MD expecting the coumadin dose to be increased. So the answer will become B in this case. And hope it's clear. And all right, probably we'll see one last question before we conclude the session, so we can be on time as we planned. And again, please share any questions or any clarification that you might need. Okay, here we go. Okay, so which of the following statements are true regarding the blood sugar control and altered insulin need in a patient undergoing surgery? Option A, being NPO and IV fluids decrease the need for insulin during surgery. Option B, altered adrenocortical activity may increase the need for insulin during the surgery. Option C, decreased insulin dose is essential to prevent hypoglycemic episodes during the perioperative period. And finally, patients on corticosteroids may need to stop them before surgery to prevent hyperglycemia and promote wound healing. Okay, so if you can type in your best response based on your current understanding, and we'll go from there. Okay, so I can see different responses here. Okay, I can see B. Okay, I can see C. I can see your liking is mostly for B and C. All right, will it be all the time? Depends, right? Okay, so let's see the truth here. Okay, so yeah, which of the following statements are true regarding blood sugar control and altered insulin need in a patient undergoing surgery? So option A, being NPO and IV fluids decrease the need of insulin. Okay. Option B, altered adrenocortical activity may increase. Option C, decreased insulin dose is essential to prevent hypoglycemic episodes. Option D, patients on steroids may need to stop. Okay, so the first one, if you can ever stop or eliminate right away, would be option D, because if you have some understanding, we always stop. A patient who is on corticosteroids, we never stop them. We had to taper them if we need to, because if you stop them, they can go into what we call as Addisonian crisis. So sudden adrenal insufficiency can put them in a state of what we call as Addisonian crisis. They can go into hypotension, hypoglycemia, and a critical situation. So option D is clearly out. Now, to understand and answer this question, we need to understand something very clear and specific, I would say. Here we go. So anytime we are going through any state of stress, whether physical or emotional stress or stress from a surgery, etc., this is what is happening in our body. It's called the stress-induced hyperglycemia. Yeah, stress can increase the blood sugar. Why? Because stress will increase cortisol. So cortisol, what is cortisol? Cortisol is same as a glucocorticoid, right? It's one of the three adrenal cortical hormones, which is needed for our body to deal with a stress situation. As a result of the release of this glucocorticoid, the blood sugar can go high. So that's, let me just bring you to the next page. Yes, again, stress will increase the cortisol, and as a result, blood sugar goes high. And let's see the next page right here. This is what I just told you. Yes, we have the adrenal gland. From adrenal gland has adrenal cortex and the medulla. From adrenal cortex comes the mineralocorticoid, glucocorticoid, and the sex hormones. So this is the one we're talking here, the cortisol. When we are going through stress, this will automatically increase. And if you know, if you hear the word glucocorticoid, think about glucose level going high. Gluco refers to high glucose. Automatically, the glucose level will go high. So when a patient's glucose level goes high, they might need more insulin to control, not less, right? So option A says being NPU1 fluids decrease. No, we heard because of the stress and the stress-induced hypoglycemia, the insulin need increase, does not decrease. Option D, we already had eliminated. No, we didn't. Option D, patients on steroids may need to stop. Yeah, we heard that because it can cause adosone increase. So A and D are clearly out. So we are between B and C. Option C, decreased insulin dose is essential to prevent hypoglycemia. Again, we heard the sugar can go high because of the stress-induced hyperglycemia. So what I will left here is option B. Altered adrenocortical activity may increase the need for insulin during surgery. And to understand, we know these facts, but the way how NCLEX present the terms would be a bit challenging unless we correctly or clearly know the underlying content. So you should clearly know, as I told you, so what are the glucocorticoid, I mean, what are the steroids produced from the adrenal gland, what can happen to them, and what is the mechanism. Then otherwise, you'll find it to be challenging to answer such questions. So the answer in this question, this condition, as we understood, is B. Yeah, altered adrenocortical activity may increase the need for insulin during surgery. All right, and I believe we were having some learning session together, and since I don't want to exceed the time beyond what I planned for, so we will have more questions in the weeks to come. Okay, so as I told you, this is the key. Stop the memorization part and start to have a thorough understanding of the content. So it's a combination of the correct content knowledge, the recollection, the retention, plus your processing ability, how you utilize information in the given question. So that's what helps you in easily and successfully getting through your NCLEX exam. And so that need a lot of practice, the correct guidance. So this is where we need to work together to achieve the goal. And again, as we were talking, it is not like any other nursing exam, because this exam is highly focusing or emphasizing on your application analysis skills, not just the knowledge part. And thanks everyone for coming in and making the session interactive. And if any other questions, please type in the chat box. You can do now or later. Can try to clarify as much as we can, and we look forward to meet you again in the weeks to come. And I'll stop this session now, and thank you all.